This is 𝗧𝗧 in Chicago, and you're watching my channel, Knowledge for Quality of Life. Friends, last week I did a vlog on APOE genotype and how it affects the fat and cholesterol metabolism amongst all the different alleles like APOE2, APOE3, APOE4. And we saw that, APOE2 are very slow in clearing fats and cholesterol, and APOE4 has a very fast clearance, which tends to lead to increase in one's LDL values. Now, today I'm going to be talking about something related to that so that we can see the whole picture that, we tend to believe and we've been advocated over the years and years, and still there is a lot of confusion. I was in that boat as well at one point. But when you see things in complete perspective, all these variables into its place, then you can paint the complete picture and you can solve the piece of the puzzle. Until you don't see the whole picture, you don't realize what's going on. So, there is a lot of misconception and, misunderstanding that cholesterol is to be blamed completely. I'm not saying that cholesterol is not important from cardiovascular disease perspective, but it's just one parameter, and we have to look at other parameters as well. So that's what we are going to look into it today. Before I go into that details, I would strongly recommend people who are watching my vlogs to please subscribe, because I was looking at the analytics. A lot of folks has not subscribed to the channel. The only reason I'm asking you to do it so that we can have a full participation in the dialogue, and I don't see too many comments and too many concerns or queries related to the material which I'm sharing, because this channel is all about increasing the knowledge base. The more informed we are, we can have a better understanding of the subject matter in taking care of our health, and we can have a better dialogue with our doctors. That's the whole thing, because this vlogs are basically my journey. As I said earlier, that each vlog is a page of my life's book. So before I go into the detail, I would again strongly recommend, if you like the vlogs and you think that the material which I'm sharing is worthwhile, do share with your friends and family. That may increase their knowledge base and their understanding in overall taking care of their health and quality of life. So let me share my screen with you. So what you see here is a normal artery here, and this is the artery with the plaque or buildup. Now, when you hear something about cholesterol, that cholesterol creates a plaque and all that, I want you to understand a little bit the complete mechanism that how things go. So if I get a cut on my skin with a knife or something, of course I'm going to bleed. And if I leave it for some time, that blood is going to coagulate and it's going to solidify. And sooner or later, within a day or two, if I don't peel or don't touch anything, let it heal itself, it's going to form a skin repair mechanism, and it's going to get hardened and hardened. And after maybe, depending on the level of cut and severity, it's going to just peel itself. The new skin is going to come. Now, that cut is external. Similar cuts we have inside our artery. I'm trying to put things in a very simpler manner. Similar cuts which we get inside our lining of our arteries over time, depending on the type of foods we consume, the type of lifestyle we are leading, and we call this internal cuts as lesions. So if you see here in this picture, normal artery, this lining through which this red blood cells are flowing, this lining is called endothelium lining. It's very smooth, pristine. in its natural form, the way nature has designed us. And because of the lifestyle, because of the food we take, because of the consumption of processed food, oils, which we consume, this lining gets compromised somehow, and we create lesions inside. Inside the arteries, there are numerous cuts happens. It's very subtle and tiny cracks, and through those cracks, because blood is flowing, blood is carrying the cholesterol in the lipid form, in the particle distribution, because cholesterol is basically a lifeline to sustain life. Each and every cell requires cholesterol to thrive. And when it sees the lesions inside, and that gets, assumes that, there's a cut here. So it just goes and try to repair it. And if you see this thing, this endothelial lining, that lining gets compromised, and over time, it doesn't happen in a month, year, it takes years to build up, depending on how fast one is building this atherosclerotic plaque, depending again on the lifestyle. So it gets beyond that thing. And this lining, the plaque formation keeps, increasing up to a point that, eventually this elasticity of endothelial layer is going to rupture, this plaque is going to rupture, and all this thing is going to get a clot form, that platelets come into rescue and try to plug it, that plaque, that rupture, and that area is going to get clogged. Now, beyond that, if it doesn't pass the blood, because we know that blood carries oxygen, and if it gets stuck somewhere, then it's a state of the heart attack, or if it happens beyond this carotid artery, it could be a state of the stroke. Now, the question is that what are the underlying issues here, which is creating this thing, right? So we have to go from the basics, that insulin resistance is the problem. So insulin resistance and dyslipidemia are the conditions where there are abnormal levels of blood glucose or insulin. I'll come in a bit that one can be completely normal on fasting blood sugar and HbA1c, but that person can be still insulin resistant. Okay, so we'll come to that in a bit. And insulin in the blood and lipids such as cholesterol, triglycerides, and etc. So there are certain issues here. There are points to be noted here. Insulin resistance is the driving factor, because that fire, the lesions were situated first before the plaque started forming. Okay, because if we eat in a way that our endothelium layer remains pristine, then there is no issue of having a cuts or lesions inside the artery, and there is no issue of building the plaque to begin with. So now the problem is that it's like what comes first, cuts or the cholesterol. Of course, the inflammation comes first. The interior lining gets inflamed, and I've shown in one of my vlog that there's a test for that. What kind of inflammation inside you can measure by doing the test of high sensitive C-reactive protein, ℏ-CRP. I did one vlog on that, so please do look at it. And if that thing is abnormal, out of the limit, then there is something going on, because that's also one piece of the puzzle. You have to see that thing to see the complete picture. So insulin resistance is a driving factor, not only for CVD, cardiovascular disease, but also for other non-communicable diseases. Nowadays, they are saying that Alzheimer's and dementia is a third type D, type 3, because if somebody has this insulin resistance, very subtle insulin resistance without knowing it, and guess what, a person is consuming, fat and cholesterol, heavy dietary cholesterol diet, and guess what, if the person is APOE 3.4 or 4.4, which we looked at it last week, that they will digest, they will metabolize cholesterol, dietary cholesterol very fast, and it's not good for them, because now you have an excess cholesterol, and you have an insulin resistance. It's like a double whammy. So you have to see the whole picture. It's not very simple looking at just one variable and looking at the cholesterol and say that, oh, you have a high cholesterol, here you go, you have a statin drug. Because, there's a stats. I've digged up quite a bit research papers and everything, and there's a stat that 40 to 50% death occurs due to heart attack when you have a normal cholesterol. And there was a well-renowned pathologist, Dr. Joseph Kraft, who wrote the insulin essays. He was doing a lot of autopsies and checking people, and he said that when he was seeing the arteries of folks inside, and there was a lot of plaque buildup, and what he said that basically he thought that they will exhibit high cholesterol values, but their cholesterol, their lipid profiles were pretty normal. So he came up with the idea of insulin resistance and insulin assays, that there are 5 different types of the insulin curves. This is beyond this topic. Today I'm not going to be discussing that, but what I'm trying to point out here that insulin resistance is the main force. If I were to put number one priority in fixing someone's health, I would say that make sure that a person is insulin sensitive and not insulin resistant. So that's number one. The second thing here, elevated levels of triglyceride. According to my understanding, 150 and below is still high, because if you have to see that your HDL and your triglyceride ratio. So this lipidemia concept is that if you have a high triglyceride, if you have a low HDL, if your small dense particles, small LDL particles are elevated, those are all signs of dyslipidemia. And dyslipidemia is strongly correlated with metabolic syndrome. And I have done one vlog on metabolic syndrome. Sometimes I'm doing things in connection again and again so that people can understand that how the whole picture is panning out, and how things makes everything is connected. It's not isolated one thing that one has to look at it. Then you have a low HDL, which I said earlier, it's part of the dyslipidemia. Then there is an issue of elevated Lp(a), which is genetically driven. You have to test once probably to see that if you are disposed of due to your mom or dad. If particularly if the heart attack runs in the family, I would strongly recommend this test to see what is your Lp(a). There is a drug being tested in phase 2 trials, phase 3 trials at 2 different companies. It's not available yet, as far as I know, but eventually it will come. And of course, any drug comes, it has a side effect as well. So be mindful of that. Now, this is just one factor, Lp(a). Lp(a) high doesn't mean that one has having a sort of a death sentence, because insulin resistance is the driving force, which creates the whole this ball of fire inside the arteries. The next one, if I were to show you here, is there are 6 graphs here of total cholesterol. Now there is a race, to be honest with you, as I said earlier last week, that folks are trying to give high strength of cholesterol lowering drugs in bringing the cholesterol down to 30 or 40 level, LDL particularly. If you look at it, the literature that when LDL, the low density lipoprotein, which we call commonly as bad cholesterol, I personally don't like the word bad cholesterol, because the cholesterol is not bad. So I don't know why people call it as a bad cholesterol, but the LDL below 100, if you bring it, your cancer risk and other infections goes through the roof. It's a very well documented too many studies have been done. So there's a race going on that front as well. I personally believe that, we need to tackle the entire thing organically in such a way that, I know that nature has given capability to my liver, that it's going to produce 75 to 80% of the demand which my body requires for cholesterol. But I need to focus on not LDL as much as I need to focus on my HDL, and particularly the tiny VLDL, which is part of the triglyceride. Triglyceride is the biggest culprit, because if your triglyceride is high, chances are that your small LDL particles are going to be high, and then it's going to glycate, it's going to get oxidized pretty fast, and it's going to be participating in atherosclerotic plaque much faster than anything else, because those are small surface area particles. I will tell you one thing, that when I started this journey, the cumulative particle size distribution in my case was 20.7 nanometers. The threshold low level is 20.5. So I was about borderline 20.7. Now in 8 years, based on my lifestyle adaptation, I'm at 23 nanometers. So 23 jump from 20.7 is quite a bit. So basically, I changed the particle size distribution without any drug. It's just by my lifestyle. That's all, nothing else. And I feel great. My LDL is unaffected, but my HDL went up, almost 122%. And my small LDLP went about 73 to 74% down. So this shows here that, between 18 to 34, 34 to 35 to 44, 45 to 54, and various stages of our life. Now, one thing you notice here, that male has a higher hazard ratio. If you look at the total cholesterol, it's pretty much in all 6 graphs. It has an inflection point, means it has a hazard ratio of 1 at 220 milligrams per deciliter, right? So there's a scientific evidence that and now we are saying that lab testing, according to our doctors, are saying that you shouldn't be over 200. But if you further divide, I looked at the literature that just LDL, what is the point of inflection that hazard ratio becomes 1, just a LDL, which we call so-called bad cholesterol, right? LDL has a value of 140 milligrams per deciliter. And now the science community, the doctors, are saying that your LDL should be below 100. Okay. Now the literature is saying that your lowest risk, the lowest risk for cardiovascular is at 140. So what I'm showing here, the difference is that between 35 and 54 age for male, you see that hazard ratio is pretty high for the low cholesterol. Okay, when you bring your cholesterol down, and mostly folks between this age, from 18 to 54, they've been prescribed quite a bit statin drugs. So if somebody is in that boat, you have to be mindful that what are we doing here? We have to see the whole picture, just not by looking at the cholesterol number and try to fix the cardiovascular risk. Also, you see here that as we age, our curve of risk gets flatter and flatter at even high cholesterol values, okay? Because we need more cholesterol when we age. It's body's demand, because our body gets more prone to infections, and you have to have a cholesterol to fight for infection. You have to have internal immunity. All these things works in a big package. It's not working in isolation. So remember that. It's very, very crucial. That's why I said that cholesterol is life. Now, the third diagram I want to share with you, and I spend the most time here, that mostly people say that when you go to a doctor, your doctor checks your fasting blood sugar, a fasting blood glucose, or HbA1c to tell you that, you are normal, or you are pre-diabetic, or you are diabetic, right? But according to the research, and it's very well documented, that 40% of people who are normal on fasting blood glucose and who are normal on HbA1c, they have some sort of insulin resistance. What does it mean? It means that their pancreas is putting out more insulin, and that insulin is floating around in the bloodstream to nullify whatever the excess sugar is coming and to bring it down so that it looks normal. So what we are missing here, as far as I understood through the literature, and I did it on myself and my family, that I started checking their fasting insulin, because you have to ask for fasting insulin test from your doctor. He's not going to, or she's not going to recommend automatically. Now, once you have the fasting insulin, I would also get check your C-peptide. C-peptide is a marker which tells you that how your pancreas is functioning, how your pancreas is giving output of producing the insulin. Okay. Now, this C-peptide is also a marker now, very well known for detecting the earlier detection of pancreatic cancer. So this C-peptide and fasting insulin, these two numbers are very crucial to include in your yearly test. Now, once you have a fasting insulin and you have a fasting glucose, which normally every doctor does, you calculate your HOMA-IR. Okay, HOMA-IR, if you are working in English units, means your fasting insulin is measured in milligram per deciliter. This is the formula you have to use. Okay, and if you are living in Canada or somewhere where they are using the metric unit, and they are measuring fasting insulin in millimoles per liter, then you divide by 22.5. In English unit, you divide by 405. Now, once you know that number is going to tell you that where you are standing in these 5 stages. So HOMA-IR is nothing but HOMA stands for homeostatic model assessment for insulin resistance. Homeostatic model assessment for insulin resistance. Now, if your HOMA-IR factor is less than 1, means you are very healthy. It means that you have a superlative fat metabolism, lean and muscular, negligible visceral fat. Now, I'll tell you that I was a little bit above 1.4, and when I was watching my lifestyle, and I avoided all the carbs and sugars and everything, and people who know me, I was always like skinny, but still I had some visceral fat. So I lost about 12 pounds, and I didn't lose any muscle weight, but I lost my visceral fat and I became a little bit more lean. So my BMI improved, and my HOMA-IR dropped to 0.75. Okay, so this is the benefit you get when you eat close to the nature, when you eat the pure stuff and avoid all the processed food and everything, all the junks. You stay healthy and you become more lean, and you are on a win-win side, from every perspective. Now, if your HOMA-IR lies between 1 to 1.5, you have a good fat metabolism, reasonable muscle mass, little but some visceral fat. So when I lost my visceral fat, I dropped my pant size, waist from 32. I used to wear 32. Now I'm wearing 30. So my doctor was surprised too that, you didn't lose that much, but, you improved. And I said that, I lost 12 pounds by just watching what I'm eating, nothing else. I'm not dieting at all. So that's where you are now. But once you cross above 1.5, that's where the problem starts, that, you have a diabetes in C2. It means that it's not going to pick up in your HbA1c. It's not going to pick up in your fasting blood sugar, because you have too much insulin probably floating around in your system. It means that you have to make sure that you bring your insulin down by not eating frequently, because every time we eat something, because we think that our body is like a machine, right? We keep chugging along, right? Every time we eat something, body senses it, and pancreas puts out the insulin and tries to nullify, send the excess glucose into the cell. And then after 1 hour, 2 hour, again I'm eating something, again pancreas is working. So basically pancreas is going on overdrive mode, and at one point pancreas is going to say that I cannot keep up with this guy. So make sure that you give your pancreas, because this is a wonderful gift of nature that we have been given as an organ. Use it wisely when you need it. Okay, so keep it distance between your eating meals. If you are eating, if you have a problem, if you are insulin resistance, if your insulin is high, skip a meal. Just like I'm doing it. I'm a 2-meal person now. I eat breakfast 12 hours apart, and I eat my dinner 4 hours before bed, and be done with it. And I feel much better at this age. I'm 63, and I've never felt that better. So you can do it. If I can do it, then you can do it. And this is for all betterment, for good quality of life. Now, if your insulin goes, HOMA-IR goes above 1.5, then you have probably, where you are standing, you can be in pre-diabetes mode, or you can be a full diabetic mode. So make sure that you get your HOMA-IR checked. And let me stop share. Make sure that before you tackle anything, you focus on your cholesterol. You need to see the whole picture completely, and make sure that you are not insulin resistant. Okay, this is the final message I would leave you with, that try each and everything possible at your disposal to become insulin sensitive as much as you can, whatever it takes to do it, right? To do that, probably, as I said, that avoid refined carbs, sugar, avoid excess processed foods, use good quality extra virgin olive oil. And I'm going to be doing separate vlog on that, because a lot of people say, a lot of doctors I have heard in their vlogs, that they are saying that go oil free. Yes, I don't like any seed oils, by the way. No sunflower oil, no vegetable oil, no peanut oil, no safflower oil, no corn oil. All these are high in omega-6s and 9 that tends to increase your inflammation. So the only source I use in my home is extra virgin olive oil, and the olive oil which I trust. And how do I trust? I'm going to be sharing that information in that next vlog, which I'll be dedicating to completely olive oil. How to distinguish a good olive oil. How to read the specs, the specifications of the olive oil, if you get one. So I would leave you with this thought that, try to become as much as insulin sensitive as you can. And you will become not only heart healthy, you will become, more health prone, avoiding all these non-communicable diseases to the best of your ability. Now, besides that, there's an exercise factor, and there's a, blood pressures also, which needs to be taken account, which I'll be doing a separate vlog on that. So once you know whole picture, then you can completely see your risk profile, that where you are standing, and you can make a better decision with the help of your healthcare provider. See you next time.